That way, for anyone that's not here with us today, they can view this recording after the presentation. Okay. So as you all know, if you have been with us before, we're with Promises Behavioral Health. PBHU is an extension of our treatment programming here. So we do residential mental health and substance abuse care with locations across the country. We have both residential, outpatient PHP services. We have virtual IOP in Texas. Um, and at every single one of these locations, what you've seen with through these webinars is what we're presenting, what we're really proud of at our communities and within our treatment centers. So family programming is deeply involved. We have equine therapy at the Ranch, Tennessee. Promises Atlanta just opened in the last couple of months. So we're growing and we're really excited to keep getting to care for and help these wonderful communities, addiction and mental health care. So if you have any questions or in these areas and want to learn more about one of our programs, you can reach out to me in the chat and I'll happy to send you any brochures or programming information that you want. And we can set you up with a tour in one of these areas as well. So Pennsylvania, Massachusetts, Tennessee, Atlanta, Texas, Florida, we're all over the place. So we'd love to meet you. Okay, you can go to the next slide. All right, so for September, next month's webinar, helping your clients build their toolbox, learning the skills your clients really need. So something we're proud of at Promises is there truly is 30 days of unique clinical programming when someone comes to a treatment center. And along with that, they're learning skills and tools that are going to help them when they leave. So Lauren's going to be kind of stepping into a bit of what that looks like and helping you use some of those tools and some of those resources in your own practices. Lauren also spoke last year with us, and so she's wonderful. She's the director over at the Ranch, Tennessee. And I will drop the link for that registration once this webinar gets started, so you all have access to sign up today. So for the CE process, while you're all here, I'm sure, you can earn 2 hours of CEs today, totally free. If you are sharing a computer with others, I know some of you said that you're going to be in a conference room or whatever today. That's perfect. Just make sure that you still have your own personal device open because if you have one device and 2 people, only one of you is going to get CE credit. So just make sure that you're on your own personal device if you want those CEs. It's also totally fine if you need to switch from computer to phone to iPad. It will follow you wherever you go. After the training, you'll be going back into your CEGO dashboard. So the same email that you used to join today, you'll receive another email, but you can also go back into the same one. And there that evaluation will be available for you to complete. And then from there, once you complete the survey, which ideally will be done by next Friday, you'll receive a certificate right away. So immediately from filling out that evaluation in your dashboard, you'll see the certificate. And if you continue to join us, you'll see that they'll save all of your certificates and evaluations in one place, which I think is helpful. And then I know I will get asked this question many more times, but slides and other resources from that are mentioned today, which there will be many, we'll be adding those to your attendee dashboard, same place, next week. So the recording will be up today, but then the slides and the resources will be up next week. Okay, next slide. All right, so during the webinar, if you have any questions for me, anything funky going on technology-wise or questions about CEs, you can put those into the chat box. That's for me. If you have questions for Rhonda and Audrey regarding the actual webinar content, which we would welcome questions for them, put those in the Q&A. I try to keep those separate so that way when they're on, we take our break later, they can just feed the Q&A questions for them and they don't have to worry about the chat. So chat for me, Q&A from Rhonda and Audrey. And that's it from me. Thanks, y'all.
All right. Welcome, everybody. Happy to be here today. It's something I'm really passionate about, is ensuring that those in the behavioral health field truly understand how to use outcome assessments to drive care, which is so very important when we talk about the quality and integrity of services at all of the sites we work or for an individual private practice. So that's one of the main learning objectives today. I often meet counselors and those in the field that they don't have a true understanding of how to use the context of the assessment. So I'm really going to spend a lot of time on that today. And more importantly, then how to integrate that into the work we do. And then some of what I'm going to talk about, and then Audrey's going to go into more detail the second half, is how do you then use that information when we're writing medical necessity? And what I mean by that is those of you that use the ASAM, those of you that use the locus, those of you that are making level of care recommendations for the patients that you're working with, how to really document that in a way that's going to benefit our patients to be able to access the care that they so desperately need. So we'll get into a lot more detail with that. Some of our main assessments that a lot of us on this call use, the GAD-7, the PHQ-9, and the BAM. I'm going to go ahead and dive into a little bit of depth with those. Again, not just really talking about the assessment, but how to use the assessment, which is one of the most important things, and the why behind why we use the assessments to really gain a holistic approach with our patients. So I'll go into pretty good detail on that. And then the majority of the second half of the presentation, which I'm sure a lot of you are interested in, either that have just recently transitioned to the ASAM 4 from the ASAM 3, we'll really touch on some of those main differences between the two of them, and then also how to integrate into your documentation for those of you that have already transitioned. What does that look like when either yourself or the staff you may supervise are now documenting in a way that they need to be using the new dimensions? So there's some of our main learning objectives for today. So I would love to just get everybody's feedback for a moment. So if you could just drop in the chat, um, why do we use outcome assessments? What is your understanding of the importance of them? And if you're a leader on the call, what are you teaching your teams? What are you saying to your teams regarding why do we use them? So just kind of wanted to get a perspective from you all before I dive in. So if you could throw some of that, that would be really helpful. Okay. Seeing a lot of great things, quality, how do we evaluate patients? I love that. The baseline, very, very important to kind of get an assessment of where that patient is at or how he or she's presenting. Identify risk factors and protective factors. I'm going to touch on that a lot today. Understanding the risk, standardization. I'm seeing a lot of great how we use it with ASAM, Optum, Locus to better understand the person that we're working with, to know what to address. Very, very, very great input from what I'm seeing so far. Drives the treatment process. We'll be talking about that, how they can help with the effectiveness of treatment. Giving patient choices. I love that. Wow, this is a great, great, great group that we have today. Identifying strengths and weaknesses. Awesome. Assess effectiveness of interventions. Great, because that ties into how we measure progress. So we're going to talk about that today. Helps the court system with direction to take. You're right, because regardless of kind of where we're working, right? Inpatient, outpatient, private practice, with the court system, all of these tools I'm going to talk about today are really, really going to help you with how to document in a way that is going to help advocate for what specifically your patients need in your care. Thank you so much for that. All right, so let's just talk, in a short hour, we can't get to everything, but let's talk about some of the main reasons what matters when we're administrating outcome assessments. So I want to talk just briefly here, and then I have some examples later around the context, right? It's really, really important that we don't have a clinical process in place where patients come into our care, regardless of what setting, and we just hand them a piece of paper and we say, go ahead and self-administer this, right? A lot of times our patients do not understand what is on the assessment, or even we may assume they understand what depression means. We may assume that they understand what hopelessness means, right? We may assume that they understand what it means to be anxious. So we want to pay attention to those things. And I would advise this by the end of today, if you don't have it, everybody leave today with your 30-second elevator speech of why an outcome assessment matters before you hand it to a patient. We don't want to make assumptions. We want to consider the setting, right? The timing and the patient situation. I have a really good example I'm going to show you in this presentation that is going to depict exactly why the context is so important. You want to know the scores, right? A lot of times I meet with therapists and I say, well, what does the score mean? And the answer I get back is, well, they have high depression, they have high anxiety. And I'm like, what does that really mean? So I'm going to spend a lot of time today connecting the dots of it's great to know the score, that's evidence-based language, right? To drive your ASAM, to drive your locus, to drive your clinical notes for medical necessity, but it should guide care, not dictate it. It can't guide care if you don't understand what the score means. So I'm going to spend a little time today making sure that all of us truly understand, regardless of what outcome assessment you use, it's really important to understand the why behind it and what it actually means. So that brings me, and this could be a whole 2-hour training on measurement-based care, but when I say an outcome assessment should be data used to inform clinical judgment, what I mean by that is you can say you do measurement-based care, but if you're not doing what I'm getting ready to explain, it's not measurement-based care, right? So it's not measurement-based care if I just have a clinical practice where I'm providing a GAD-7 at the beginning of each session, and that's all I'm doing. And I might just be putting the score in a note, or I might be putting a score in the treatment plan. Measurement-based care and adequately using outcome assessments is getting that baseline, like a lot of you said, and then how is that being integrated into interdisciplinary care with the patients? And I'm going to show some examples of that, right? So if I'm in an inpatient, how am I integrating that into the entire interdisciplinary team, right? Am I talking to the provider about those scores? Am I talking to, the counselor, the BHT team, the nursing team? All of that really affects how we guide and inform clinical judgment. So we'll talk a little bit more about that. Are you integrating into your treatment plans, right? For those of you that do treatment plans, and I'll give you guys some examples that you kind of can take as resources for you, but we should be linking results directly to the context of the assessment, right? So depending upon how that patient's presenting, as we're observing them, as we're doing clinical interviewing, as we're getting information from the outcome assessment, it should be directly related to their goals, objectives, and interventions. And that's essentially individualized care, okay? The team-based approach, something really, really important is that interdisciplinary team. So I know a lot of us, especially us that work for places that are Joint Commission accredited, and we have an expectation around interdisciplinary documentation. Okay, so we can say that, but what does that really mean? What that means is on your treatment plan, it should show up how different members of your team are specifically supporting the patient to meet the goals and objectives. And I do have some examples of exactly what that should look like, but that's the team-based approach. And not only in-house, right? That should be the outside providers. Did you contact and get a ROI for the providers for where the patient was before your center, right? Or before your private practice? Then additionally, when the patient discharges, do you have a process in place where you're getting those ROIs so the patient experiences that much better when they leave our care, right? So now we can coordinate with those providers, with those next level of treatment to be fully interdisciplinary, right? And that's what that means. And when we do that, we're able to show the progress that the patient has made so far. And then it's a continuation of, because we tell patients and families it's a continuum, it's a continuation of care. But if we really don't have that team-based approach, is it truly that? So it's really important. I know it promises something that's really important to us is the integrity of our clinical model. So whatever we say we're going to do, outcome assessments, measurement-based care, integration, all of those things that we're actually doing it as part of our clinical practice. Something that some of you actually listed in the chat, which was great, was embedded into your workflows. using it consistently. So at intake, you get the baseline. You have specific follow-ups with our team. We do it every single week in our individual sessions because we want to see if the patient is making progress or not. And then we also say whatever's in that care plan should show up in the aftercare plan as well, so they can continue on at the next level of care, whatever that may be. So you definitely want to have a clinical system where you're showing the progress over time with all of your patients. So these are our main, they're not all, it's not all inclusive. With the time I had, I chose three. And together, we're going to just explore these three outcome assessments just a little bit deeper. So when I gave the example about interpretation and use and context of an outcome assessment, I wanted to just show you what I mean by that, right? So if you look at these two case examples, they have the same score. So this depicts the example I gave. If I'm a clinical leader and I'm asking a therapist, and all they say to me is the patient has moderate anxiety, if they truly don't understand the context of the assessment and interpretation, we could be assessing inappropriately, right? We could be and not intentionally, but then we could be creating a treatment plan or possibly diagnosing a patient with a mental health disorder that may not have one if we're not paying attention to this. And these two examples show that right there, right? Patient comes in example one, they have a GAD-7 score of 14, which is moderate anxiety. The context for this patient is they're reporting months to you of restlessness, they're on edge, they're unable to control their worrying. The patient reports symptoms of affecting their sleep and inability. It's now affecting them at work also. So if you interpret that clinically, you think, okay, this score aligns with the patient's clinical presentation, right? There could be a likely diagnosis of GAD, could be appropriate. Obviously, we're going to get more information. We're going to probably consult with the provider. But we now can start to use those specific symptoms that are showing us the patient's impairment to not only help us with what Audrey's going to talk more about, the justification for the need of treatment at that level of care. But what's going to be great is this is how you're going to individualize your treatment plan. You're going to individualize it to exactly what the symptoms, behaviors are that the patient is presenting. And we have some of them right there. So then let's bring us to case study two. This is more of a temporary stressor. Patient comes in, they're saying, oh man, my anxiety, they just completed an intense school program. They're reporting there was a lot of stress, very intense stress, not a lot of sleep, worrying about it, but they expect it to resolve now that classes are over, right? So the clinical interpretation of that may be, maybe this is just more situational anxiety, right? Not necessarily an anxiety disorder. Follow up 100% warranted because as maybe there's the next semester we're going to prep them for. So it may not be a diagnosis. We're still going to support them. We're still going to create treatment for them, right? Maybe things change if the symptoms persist, but I can still help that particular patient in individualized treatment planning because it's going to show up again. So now I'm working with this patient as periodically when a stressful event happens, let's talk about some specific skills that we can teach you to kind of be proactive and get in front of it. So just wanted to kind of show you that example of why it's so important to get the specific context and then interpretation in the work that we do. That's going to guide specific care versus generalized care. And then we share this information with the team, right? So all those other in the disciplinary team, they understand specifically what we're working with this patient. So I just want to look at the GAD-7 here for a moment together. When a lot of times, and I'm just being transparent, when I talk to therapists, they do not know the specific questions on the assessment. So for me, when I'm training clinical outcome assessments, it's one of the most important things I say for a therapist. You must know and you must look, because if we don't look, we don't know. Okay. So something that's really important is I want to assess this and use clinical judgment. I want to see, how is the patient endorsing their anxiety? Do they have trouble relaxing almost every single day, right? Are they saying that they're extremely anxious, on edge almost every single day, right? Maybe it's not hard for them, to sleep, but maybe the next patient it is. If I don't know the specific context, how do I write the individualized treatment plan that's going to meet the need of that particular person? So it's really important to just take a quick peek, not only to have the score, but to see how he or she is identifying. And the truth is, we all know this working with patients. Sometimes they're unable to identify, and that's fine. That's why we use our clinical judgment, right? So a patient might come in and say, "Oh yeah, I'm not anxious. I don't fidget or anything. I'm fine sitting still." But the entire time we're in the interview, they can't sit still, or they can't sit in group, or they constantly get up. That's where you use clinical judgment, and we can help make that connection for the patient. I wanted to give you an example. You see in number 2, I think it talks about if a patient identifies consistent nervousness, and that's how they're identifying their anxiety. So to be specific to that, I gave this example here of some specific DBT skills, okay? And this is what I mean about connecting specific skills to how the patient's presenting in your treatment plan. So while I'm looking at what approaches to take, I'm going to stay away from acronyms of, we're going to teach them a DBT skill, within the first 3 weeks of treatment, and they're going to utilize those skills and it's going to be part of their safety plan, right? No, I'm going to be very specific, like I have here, right? If I have a patient that has extreme nervousness, I am going to, in the goal and objective, I am not only going to teach them, but they're going to practice, and I'm going to put the specific skill that they're going to practice and when in the treatment plan. So I'm not just going to write the word mindfulness, right? I'm going to say specifically that patient's going to take a 5-minute breathing or grounding exercise, but I'm going to make sure they understand how to do that appropriately, right? And that's why we practice at Promises every single day in our clinical group. We not only introduce the skill, we practice it, and then we have a follow-up group activity in the afternoon so our BHT team can practice it and show them how to integrate it into care. Because if we don't practice and he or she doesn't practice, the likelihood for them to use it is less. So if I have a patient really anxious, the examples show they have difficulty doing things at work, right? Okay, let's build some of that mastery with them, right? Let's start teaching them how to accomplish a really small task at a time versus avoiding, right? So we're going to put some specific language in there to help them understand how to do that. And sometimes you have to break it down for them, right? So I won't go into every example, but you'll have this, and I'll also be giving you some treatment planning examples. But I just wanted to show you whatever it says in the assessment, start targeting those things, right? Here's just another example. There's tons of them. So let's just say for the PHQ-9, the patient saying they just have a very depressed mood, and sometimes that just turns into a very intense crisis for he or she. Okay. So when I'm writing a treatment plan, I'm not going to just put like the acronym TIP, because we're really big on when you write treatment or you write a plan for a patient and family, we need to make sure that he or she understands it. So if someone else picks it up, they would be able to know exactly what we're saying, right? The patients need to know when you're writing a treatment plan, it has to be in their language, something that they can pick up and say, okay, that's right. Rhonda told me, I'm not going to remember what tip means probably. I know I'm not. But if they start teaching me and we practice, what does it mean to use temperature, right? So when a patient's getting, extremely dysregulated, we're going to say, you know what, maybe we could use an ice pack, right? Maybe we're going to encourage them to go splash cold water on their face. Maybe they need to, if they're at home, if your patients, maybe you're in an IOP level of care, if you can, go get in the shower. We need something a little bit more intense when a patient is into a crisis mode to help distract and to help regulate their brain. Maybe it's intense exercise. They're going to sit there and they're going to do 20 jumping jacks. Remember, we're trying to distract the brain, but also distract from whatever that intense emotion is that is getting them into a crisis situation. But I have to show them what this means. I can't just, say paced breathing and we never practice. So the reason why we teach paced breathing is because we're trying to regulate the heartbeat, right? We're trying to shift that focus from the patient. So I need to show them, what does that mean? The inhale is going to be a little shorter, maybe just 4 seconds. and the exhale is going to be a little bit longer, 6 to 8 seconds. And we're going to start regulating their brain so they can get into a state where they can calm down and focus and be able to kind of move on productively. And the same with progressive muscle relaxation. These are going to be my objectives and interventions on my treatment plan. Okay. So the objective is always what the patient's going to do, and the intervention is always going to be what the staff is going to do to help that patient learn and progress with their goals. It might be self-soothing. A lot of us use this. We ground through the five senses. We might ask a patient, when you're feeling really dysregulated and it's really hard for you to concentrate and you're feeling the physiological effect in your chest and you feel like you can't breathe, different things like that. Whatever it is for the patient, oftentimes I try to get them to focus on, what do you see in the room? I want you to look at 4 things that are yellow, right? Your brain can't focus on multiple things at once, right? So try to get them using their 5 senses, but again, practice it, show them how to do it. It's something we want to incorporate into their day, not just having skills when they're already very dysregulated. And then here's just another example. You'll have that if you use the DVT skills accept. So we can just start to teach them different things that they might be able to do. Some of them might read, and hey, some of them may say, I have nothing. All I did was use. But that's okay, because now we know where to start, right? We need to help them. What might be a hobby? What might be something they're interested in? Maybe they never did a puzzle. Let's bring those out. Sometimes they get the crossword puzzles, right? Sometimes in our programs, we integrate like music. We do comedy stuff, talent shows, whatever it is, we're trying to get them connect to something else. So I would highly suggest, if you are in an inpatient setting, that you incorporate a lot of these things. So then when we say, why don't you help someone else? They already made the connection. At our program, we do service events with all of our alumni. So we already have groups every single weekend on positive psychology where we're teaching patients how important it is to help others and how to give back. So when we then use these terms in treatment plans or in aftercare or staying connected post-discharge, there's already that common language connection. Here's just a couple examples for you of how to incorporate the skills. And again, all of this goes back to the outcome assessment. So I'm trying to make the connection to you, depending upon what your patient is presenting to you. Then you're going to use specific skills, because remember, talking about something in itself is not going to help the patient be able to better manage that when these things do show up for them physiologically, right? So if you have a patient that's really struggling with sleep, right? And you go back to that GAD-7 on the PHQ-9, they're saying, listen, I'm not falling asleep, I'm not staying asleep. And we know how that then contributes to their mental health, their physical health. Here's some examples of different things you can do, like help them create their own wind down routine. Especially if you're in an inpatient setting, let's start that with what we have now, right? Maybe they go to their room, maybe they, have a gratitude journal, right? Maybe they practice some of the skills and techniques of mindfulness before they go to bed, things like that. If they're out in the community, maybe for them, they can go get some tea, or, even in treatment, we have the adult coloring books, they can read, whatever it is. We either want to introduce new things, and we want to build off what's working for them to kind of calm their brain down so they are able to go to sleep. So here's just some examples. I won't go into all of those, but you will have them. I know at our program, something that has been really, really effective is ice packs, especially when a patient is really under distress. I see patients holding them in their hands. I see patients putting them on the back of their neck. I met one patient a few months ago. She said holding it right against her chest helped. So again, we're helping them to find out what works for them. But if we don't introduce it, if we don't teach it, and we don't practice it, they're not going to leave with that pretty intense toolkit that they'll be able to use when these things present when they go home. So it's really, I can't say enough how we take the outcome assessment, we take clinical judgment, we take observation, and we should have specific skills attached to the behavior and symptoms our patients are exhibiting, and how are we helping them and teaching them. So that brings us to the BAM assessment. Those of you that work with patients with substance use disorder, Little smaller, a little harder to see. But my point in bringing this up is that if you use this assessment or any of your staff do, please make sure that they understand the purpose of the assessment. So the Brief Addiction Monitor is supposed to be used, it's an evidence-based measure that should be used in your practice to be able to measure progress in substance use disorder care. Okay. So the goal of this assessment is to identify the patient's risk, their protection, and their use. So you get your baseline based off of what they're presenting, he or she, use your clinical judgment, use additional assessments, start building out what this patient needs. So I'm going to give you a couple examples of how to utilize this in treatment planning. So at our inpatient facilities, this is how I structured it from a clinical process standpoint. When I'm working with clinical teams, there's specific questions on this assessment that talk about, like, let's look at number 12. Does your religion or spirituality help support your recovery? So all of us that use a BPS and all of us that use other clinical assessments, we also ask these questions because they're important. Because if a patient is already telling us that spirituality and religion is important to he or she, and they're staying connected, that builds protection for that particular patient, right? So then we know that we can encourage them to continue to use it. Or maybe we have a patient and they're like, I don't have any of these things. No, haven't spent any time in work, school, or doing volunteer work. No, in the past 30 days, have you been bothered by any arguments or problems or getting along with family and friends? And they're like, no. It helps us to know how the patient is seeing his or her issues or not. We should then take that information and actually use it in the particular treatment plan. So, one of the ones that I like to focus on too is physical health. If a patient is identifying to us that they have poor physical health, that is a risk for many reasons. That could be a whole training in itself, right? How that could possibly make their other medical issues more severe, how that could exacerbate their mental health, all of those things, right? Vice versa, their substance use, all of those things. So if a patient says poor, that should be incorporated into their treatment plan. And as a therapist, would already be thinking of, okay, how am I going to integrate the entire interdisciplinary team to be involved in this? Because if I don't share this information, that's not interdisciplinary care, right? So it's important for me to connect with my in-house provider, or if you're an outpatient, with their outside provider, because we need to start tackling whatever it is that is an issue for the patient that has physical health issues, right? Especially when we're talking about pain. We definitely don't want to not address a patient's pain. Something else that's really important if you're working with substance use patients, one of these questions is going to ask about their sober support network. That's really important. So, as a clinical leader, I work with my clinical leaders to say this: if a patient says no, that they have no home meeting, that they have no sponsor, that should be part of our treatment plan and our aftercare plan. So by the time they leave our place, we have a plan set in place, right? We've already looked at what are the local NA and AA meetings in their area. We have dates, times, and locations set up, right? If they don't have a sponsor, they're working with their therapist, their alumni coordinator, or their case management to make sure they have that. And this is the reason why, because we know in this field that that is going to help them maintain long-term sobriety. So one of the ways I teach assessment is every single question is asked for a meaning and a purpose. The biggest thing you want to ask yourselves and your teams is, what do you do with the information you have? So I ask that all the time, whether I'm meeting with an executive director, whether I'm meeting with a clinical lead, whether I'm meeting with a provider, whether I'm meeting with the director of nursing, it doesn't matter to me, an alumni advisor. What are we all doing with the information that we have? Think about how that affects the patient when they provide us critical information and we don't do our due diligence with it. I always try to relate it back to if it was myself, my family, my loved one in treatment. Would the team be targeting what is truly a problem for them and coming up with a viable plan? to not only help them while they're in our care, but so much more importantly beyond, right? So it's so important that you know how you get to the score. I did a little cheat sheet on the left-hand side for those of you that use this assessment. I showed you exactly the questions that are associated with risk, the ones that are built for protection, and the use questions. And then you can then incorporate that into your language, and Audrey's going to cover that the second half. So when you're writing ASAM and locus, you can be very specific to document the patient's risk. And I'm always going to tie it back to that. And I'm going to tie it back to that because we all are here today, I'm sure, because we want our patients to get better. But for a lot of us that use insurance and those things, right, for our patients and our patients use insurance, we have to have very, very good documentation to show medical necessity. What better to use than evidence-based approach and language? So I wanted you to just be able to see that of how you could even better write those risk areas. And then I want you to take those risk areas, and that should be on your treatment plan. So if they don't have a sponsor, your treatment plan should be specific to getting that set up while they're in your care. Here's just another example of how to take that, and it's just very few examples of how to take the information that our patients just identified as risk and protection and put it into your treatment plan with specific ways that we can follow up, right? So if a patient comes in with poor physical health, do we have a follow-up physical exam? If you're in outpatient, you don't have a medical provider or just in private practice, encouraging the patient to schedule that. Maybe there's certain labs we follow up on, right? In-house or out-house providers, incorporating them, making sure they know, making sure we have PCP appointments, especially on our aftercare plan within 7 days of discharge. If they're having difficulty sleeping or staying asleep, which I feel like is so many of our patients, are we consulting with the psych NP or the other provider? Have we looked into medication management? Is our clinical team teaching them the skills that I talked about earlier on, right? What's their wind down routine? How do they dysregulate? Do they know mindfulness? Do they understand distress tolerance and what that means, right? And how to do it? So here's just some more examples of how you could incorporate that. If a patient comes in on the BAM, one of the very important questions also is about cravings and urges. And this really helps you when you're writing Dimension 1, right? When we're talking about post-acute withdrawal. And I don't have time to go over it in the presentation today, but I did create a tool for you that think about, and I want you to think about something from a psychological standpoint and a mental health standpoint with Dimension 1. Oftentimes we think of Dimension 1 is only post-acute withdrawal when we're talking about substances. We can also relate that to mental health, right? So we have patients that have urges to isolate because of their depression, right? So we also have the ability in our clinical documentation of medical necessity, and that's just one example. I have tons of them for you in the resource that I'm going to give you. But we can also correlate that to mental health in Dimension 1. What kind of urges and cravings do they have based off of their mental health symptoms and diagnoses too? So you can add that as well. And then here's some protective factors, right? Are they attending self-help meetings? If they are, wonderful. Let's still make sure that's part of their aftercare, right? And maybe they don't want to do AA or NA, but let's have them be integrated into some form of connection, smart recovery, alumni meetings or events, celebrate recovery, whatever that is for them. There could be NAMI, if it's more primary mental health, or a combination thereof. And then here's just some more examples of how you could integrate maybe their faith-based practices into care. Encourage them if religion and spirituality is important to them. Maybe that is part of what they do, at the beginning of the day, at the end of the day, to kind of help ground their mind to go to sleep. Everything I'm saying just needs to be individualized to the patient. So we know our patients best, you know your patients best, and you know what would be kind of appropriate for he or she. So to kind of tie it all back together, just remember the context is really key. Understand the tool. I'm going to encourage all of you. If you hear nothing I say today and you either use outcome assessments or you supervise a team that does, please make sure they're familiar with the questions and the intent of the assessment. A lot of therapists will say to me, well, they don't take them seriously, or like the assessment says 0, 0, 0, 0. And I put it back on them. How are you explaining the assessment to your patients, right? Making sure that they actually understand it and the why behind it and the importance of it helping us to assist in individualized treatment planning and care. So you want to know what your 30-second elevator speech is when you meet a new patient and you're getting them incorporated into using those. Differentiate distress versus disorder. Pay attention to that. Pay attention to what the patient's telling us, what the family's telling us when you meet a new patient. Interpret the scores in their context. Numbers alone do not equal a diagnosis, okay? It's really important that we're appropriately assessing our patients, that we're hearing and we're observing what our patients are telling us, not only verbally, but through actions. Use your clinical judgment. Always consider the broader picture of symptoms, history, functioning, what's presented, collateral information you get from their support system, from their family, and looking at records if you have them from prior placements can be really, really helpful. So before we wrap up this section of the presentation, I just want us to take a look. I want to pull it all together for you, all the things that I said. So let's look at this case study together. We have a 43-year-old who's struggling with anxiety and depression, 4 overdoses, a past suicide attempt, and 3 prior treatments, and never did aftercare. So the patient is scoring with moderate to severe depression, and GAD-7 14 would be moderate depression. So let's just look together at how I would guide to develop an integrated treatment plan example. So obviously I'm not touching on every single thing, but I'm going to show you, and this is how I train my therapist, that each of those areas that I'm going to address, it has to be specific to the patient, what the patient's doing and what the staff are doing. So let's look at this. The goal should always be in the patient's own words, okay? As often as possible that you can get direct quotes from the patient is going to be so important. It's their treatment plan. It's their treatment. So think of the way that you engage them in their treatment plan development. So I'm going to ask Mike, like I just heard you tell me, I see it. You've told me how much the depression is impacting your day to day. What is it that you would like to work on? What is it that you would like to see different? And Mike says back to me, I just want to feel less depressed. Like I want to be active. So something that's really important, it's not only important in quality care, but if you're Joint Commission accredited, it is an expectation that you incorporate patient strengths into treatment planning. So one of the things that I took off of Mike's bio is he said he's curious. He sees that as a strength of his. So I'm going to utilize that strength. So if you're curious and we're trying to work through these things, let's be curious together and let's use that curiosity to be open-minded to learning new skills and practicing to actually improve your mental health. So Mike's going to use his curiosity to improve his mental health. Goals are often a little bit more broad, but you're also able to measure them, right? Something that we teach that I think is really important on a treatment plan is you always have the patient's diagnoses. Okay, so we see one of his diagnoses is major depressive disorder. So now let's look at the objective. So I'm going to give you a couple quick pointers that would always make sure your objective is written correctly, intentionally, individualized, and measurable. Okay, the objective should always be what your client is doing. What is he or she doing to achieve the goal, right? How and when, okay? What are they doing, how, and when? Adding in outcome assessments as much as possible, because that's going to help you track progress. And many of you said at the beginning, you have your baseline and then you continue to track that progress throughout in a discharge, right? If you don't measure it, how do you know that there's improvement? The key with measurement-based care is how are you utilizing the measurements to incorporate next steps, right? So I would highly recommend in your objectives, you use what I said, be specific as possible, and use the outcome assessments that are appropriate to the goal that you're working on. So you see in my examples, I use the PHQ-9. So let's look. When Mike is experiencing intense emotions, so this is the stop skill in DBT, but instead of me just writing that, we're going to help him understand and teach him how to practice stopping. Let's just take a step back for a moment. We're going to observe and we're going to teach him how to proceed mindfully, which I think could help all of us, right? When we're dysregulated, sometimes we just need to stop. Don't respond immediately. I don't know about you, but how many of us, you start to type that email or you start to type that text and you go back and you delete it or you rewrite it and you delete it again before you send it, right? So this is just a good skill in general when you're feeling an intense emotion for us, our children, whoever. Let's teach ourselves. Just stop for a minute. Just take a step back. Observe, maybe use some mindfulness, some regulation, and then proceed in a way that's going to be beneficial for you, right? And we're looking for him to reduce his PHQ-9 score from 17 to 13, right? So when I reassess him, I'm going to see if things are getting better or not, and that's going to make my next objective, intervention, and goal. So here's another one. When Mike is experiencing the urge to stay in bed and not attend group, he will just get up and sit on the edge of the bed. Sometimes it's baby steps with our patients, right? Because if you remember in the vignette, it talked about Mike sometimes just doesn't want to be active, right? He'll just stay, kind of lay in bed. We could say, hey, he's not going to group. We could say he's not going to work, whatever the case is. Sometimes it's just about getting that routine. So instead of just laying there, maybe just get up, sit on the edge of the bed, and maybe the next step is, X, Y, and Z, maybe a little stretching. Maybe they have a glass of water next to their bed, whatever it is that's going to kind of get him up and moving. Mike will create a safety plan with his counselor within 72 hours of admission. And why I made that connection is because if you remember in some of the initial information that it gave was the suicide history, as well as that ties from what he said directly into his depression. So it's going to be really important that we get some of those specific behaviors, triggers, and skills so we can share those with the treatment team right away. So then the intervention should always be the staff member. The intervention should be what specifically is the staff member doing? Who is it? What are they doing? And when that's going to assist the patient in maintaining and achieving their objective and goal. Okay. So here's a couple examples. Therapist in session, or it could be in group, however it works for you, is going to practice with Mike. In this case, I'm saying an individual session because we do it in group and we're going to reiterate it in session to make sure that Mike actually understood what was being taught. And then we can practice the situation. Therapist is going to administer the PHQ-9 weekly in an individual session. That's going to help us, like we said, kind of gauge progress, lack thereof or not. Provider is going to meet with Mike weekly to assess medication efficacy. Very, very important for us to know, is the medication the patient on working or not? So we want to share that information from the clinical assessments with the provider as well. That's interdisciplinary care. Counselor is going to assist Mike in creating a safety plan within 72 hours of admission during a session, identifying ways that the team can mitigate risk. I can't emphasize this enough. If you have a patient that's coming in with hopelessness, with severe depression, with suicide thoughts, with suicide ideations, it is then our job, especially if like we're an inpatient, to be coming up with specific ways that we as the team are going to mitigate risk for that patient. So sometimes there's increased rounds. Sometimes there is urgent flags put in charts. Sometimes we might have them meet with the provider more intensely. Sometimes it's just creating that safety plan and reviewing it several days after. It's us, if their family is a huge protective factor for them, getting that family engaged right away, whatever it is to mitigate risk. Maybe we do additional room searches because of the patient's risk, right? Patient comes in and he or she has a history of cheeking medication. We should have a specific intervention of how we may handle med pass differently. Maybe the patient sits with the nurse just a little bit longer to make sure they're not cheeking meds. Whatever information comes in, it's that we're just targeting it very specifically. That's why I'm giving you multiple examples. Because oftentimes therapists, and I've been working with therapists for a long time, I'm one myself, we we overthink treatment planning and we write in generalizations. Again, not intentionally, not to say we're not a good therapist, not to say the intent is not to help the patient, but I see a lot of terms like aftercare, coping skills, and all of those things. But what are we specifically doing? What behavior is that coping skill targeting? And are we clear about it? And what are we doing specifically? Because there's certain skills for certain presenting symptoms. And that's why it's so important not just to say like DBT or CBT. What specifically are we doing? Right? Because if you have a depressed patient, we have specific energizing skills that we're using, right? To kind of get that body up and moving, kind of get that brain activated. So it's really important that we're teaching and leading and training our teams and ourselves to understand the differences. So we present things and teach things that are going to activate that part of the brain that is actually going to help the patient feel better. So it's really important we teach all the brain states to the patients too and to the staff so they understand, depending about how this patient is presenting, how we respond is critical. And that's what trauma informed care is too, right? The way that we respond and understand is significantly important. So I have tons examples of how to do this. I know Callie said that you guys can put questions in the chat. We'll look at that on the break that we're getting ready to take. If anyone has any additional questions that we don't get to in the chat or at the end of the presentation, or is curious about additional skills, you could always reach out to Callie or email myself, and I can help you with that. All right. We're going to head to the break. I'll send over to you, Callie, to see if you have any announcements before the break.
With I'm going to start with the local. Welcome back from your break, everyone. We're going to start with overviewing the LOCUS, the level of care utilization system. This system was developed in 1996. It was created for the pure intention of helping clinicians guide that level of care decision making, utilizing an array of information that they are collecting from the client themselves to basically quantify, get some information in a quantifiable, measurable way so we can implement treatment, effectively develop treatment plans. And the target audience are the clients that have mental health and substance abuse issues, as well as those clinicians that work with those populations. The four main objectives of the locus is to really assess the needs based on the 6 dimensions, and we'll go over those 6 dimensions. Provide a continuum of care based on the resources at each level of care, and we will go through that as well, what those levels of care are and what that continuum of care looks like. And then, of course, providing that quantifiable data to support level of care recommendations so we can show the client, here's what it looks like you meet. We're also be able to give that information to our providers to support the fourth and final main objective, which is to guide documentation and support clinical management for each one of our cases that we're working on. The levels of care that they have within the locus, of course, is that recovery, maintenance, and health management. And what this is, it's basically trying to figure out what the least restrictive environment is for this patient. It's going to focus on stability, gathering health and wellness information on this patient and figuring out what is a suitable environment for this person given their current symptoms and their history. The low intensity community-based programs that started many years ago when everyone just kind of let everyone out of those public institutions when we went to the community care based models. So this low intensity involves community mental health centers, outpatient providers. It still gives them a structured and supportive environment, yet they have that case management piece as well, whether that's through their insurance and a provider. The second one is that high intensity community based services. This would be someone, if you, depending on what your community based programs in your area are called, but you've got outpatient where they're going in that low intensity, maybe once a week, once a month, but the high intensity, they may be getting home-based supportive services. They may have several case managers that are coming in, somebody to help with daily functional needs, someone to help with mental health issues. Whatever that looks like, it could also incorporate a day program or a rehabilitative type service that increases the intensity of their services, but they're still home. They're still connected to that community supportive system. Now, the medically monitored non-residential services, sorry, reading that was a little bit difficult for me, is where we're providing a higher degree of structure and support while monitoring in a non-residential setting. So this could be a partial program. This could be an intensive IOP program. It can be an assertive community treatment, like an ACT team. So a lot of our community outreach programs do have an ACT team. So they are getting in there and helping that patient, giving that extra support while they're also trying to apply those skills independently. So they have that support. We have that, we're not completely so focused on structure, but they are providing a structure and we're giving them an example of or ability to actually try to apply those skills independently without the supportive services. Now, level 5, we've got that medically monitored residential services. These levels involve a residential setting with medical and psychiatric monitoring and keeping them in that structured environment. We want them to stay that has 3 different levels. So 5A is just an intensive short stay. So this could be 72-hour hold, but not required, but their choice, coming in for a short time. They get medication settled and then they're ready to go. That moderately intense immediate stay, same sort of environment. And then C, we've got so you've got 3 levels there with that. Our locus, our level 6 with this medically managed residential care, we're looking at more intensive levels of care here. Typically an acute care setting or a similar type of facility or state facility. These are individuals with severe behavioral health issues and health conditions that require a higher medical monitoring to help provide that structure and keep them secure. So we're looking at acute settings with level 6, and here we're looking at that more residential type setting. The 4 variables that we have with the locus involve that environment of care. So that care environment, what is the setting that they are in? Are they getting it in a residential facility? Are they getting their services in an outpatient environment? The clinical services, what type and intensity are these services that we're providing? Is it just therapy? Are we doing what type of therapy we're doing? And also the medication management piece falls into that variable as well. The crisis resolution and prevention services, we're looking at strategies and resources that we are helping to provide to manage the crisis that's happening at this moment and help prevent the mental health or the substance abuse relapse at this point in time. The dimensions that we use in the locus include risk of harm, functional status, comorbidity. What are we using? Recovery environment, treatment and recovery, history, engagement and recovery status. And then my name is covering that last one. composite rating. So how are we going to rate these things? So when we get into these areas, the risk of harm, what are their behaviors? How risky are they? If they continued on this path, what is the potential for harm and risk to themselves? Is their judgment impaired? How well are they controlling their impulses? Do they have impulse control? The functional status, we have their ability to complete those daily tasks, and are they holding themselves accountable, and can they manage those responsibilities that they have on them? And of course, comorbidity is, are we considering the medical interactions, the addictive, the psychiatric conditions? How are they working in conjunction together at this point, and how are we rating their level of severity here? The recovery environment. Is this environment supportive? How stressful is this environment? So we're looking at that aspect. Is it a positive or negative thing that will help support recovery or deter or make a negative impact on recovery? And then our engagement and recovery status. How willing, how motivated are we to engage in this treatment? Do we understand what knowledge do we have about our own condition and our behaviors that influence that condition? And are we supporting our own road to recovery? And then our final one, how we are going to rate this. Now, the locus is really based and rated on a 5-point scale. The scores contribute to that composite overall score that will help us recommend the level of care. And it is a tool that is meant to help in that decision making. It is not meant to replace our clinical judgment. So if we feel that a certain level of care is appropriate, we are supposed to use the data we collect from these dimensions to help support that level of care decision. Sometimes most of the time, our level of care projection on the scores also match our intended and what we think the patient matches, level of care that they should go into, but not always does it actually meet up with what the patient is asking for or what they think, what level of care they think they should be in. Now, also the locus will also integrate or focus on the integration. How collaborative is that integration that we are using to decide which level of care is best or help us make those decisions? The minimal integration or minimal collaboration level of integration, it is looking at those primary care providers. They're separate from the facilities, are not connected to any sort of hospital setting or an outpatient clinic. This is just you going to see that primary care provider. Many of our patients who start therapy or have a extreme crisis and have to seek the need to be hospitalized have only been seeing their outpatient provider, have been managing it with medication, but not necessarily working with a therapist in an outpatient setting or in a community care setting. So that medication management piece has been the only thing that they've had intervention with. The basic collaboration is we are also using a healthcare provider, a behavioral healthcare provider in conjunction with our primary care provider. Now, basic collaboration within the mental health field together is the proposed therapeutic intervention that all of our payers support, and also the best outcomes are associated with meeting us at this level, at least starting here, because you've got that connection and working collaboratively together with the medication piece, so that bio piece, and then the behavioral health piece with going into therapy. The close collaborative integration level is an on-site yet minimal interaction or integrative setting. So we've got our behavioral health provider, we've got our PCPs, and then we have a separate system that either our providers are also there or we're separating that. But this would be where we're looking at a PHP, an IOP starting to get involved a little more, or maybe moving that direction. We may not be involved in a PHP at this point, but we may be moving in that direction. So the clinical care providers and the PCPs are still separate at this point, but when we move into that partial, they are completely collaborative. They're working together. They're all on site with one another. So with that close collaboration, you might be doing some group therapy, you might be doing individual sessions, but yet your medications are managed outside of that. The partial, we all know what partial hospitalization is. We are going to have that connection between the medical providers, the psych providers, the therapists, and we're all a part of one clinical team working in conjunction with that patient to help reach those goals, to help reduce those symptoms. And then the full integration is when we are in those inpatient settings. Now, here is a scoring example. Many of you have probably seen this scoring example with the locus. Each dimension is rated with a low, moderate risk level. So you've got ranges with each one, and that's what it meant by the 5-point scale. You can give them a number in this area. The higher numbers, you're going to add them up, you're going to score, and then you're going to get that composite score, which would recommend the levels of care. We aren't going to do an example of scoring a vignette or taking Mike from Rhonda's vignette and with the locus, just because I really wanted to maintain our focus on the ASAM. We're going to do that with the ASAM after we review the actual ASAM as well. So we'll get that example right in there. All right, so with the ASAM 4, how many of you have actually moved to utilizing the ASAM 4? My company, we're like straddling between 3 and 4, and it is a very difficult task to start getting into. We really try hard, but it's a very difficult new scoring system. It doesn't equate well with therapists simply because they've changed it. We're not on that 5-point scale. We're not just severe to moderate to mild. We don't have the numbers 1 through 5 anymore. We have all these letters and these numbers with a level of connected to a level of care. It is still somewhat simplified, and we'll go through that. We just, as clinicians, see multiple things and our brains freeze. We're like, we don't compute data. We don't add numbers. We're not accountants for a reason. Yet the scoring system on the ASAM-4 looks like some accounting form to me. And so I've heard many clinicians just talk about how they don't understand it. They get confused. So we're going to try to work through what the changes are with the ASAM and then look at a vignette, and we'll give you an example of a scoring system. So essentially, the criteria for ASAM, very similar to locus. We're evaluating those individual needs ongoing, not just at admission, not just before admission, while they're in treatment as well, whether that's outpatient or inpatient setting. It definitely helps us develop or determine that level of care, which is great. So it's determined. It helps to push us into that individualized treatment. If you're writing treatment plans for an individual within an inpatient setting or an outpatient setting, and if you've ever looked, have taken a course on treatment planning, or even had your notes audited by payers, they're pushing that individual treatment plan because we do need to tailor things to the specific needs of the patients that we're seeing. So many of us will come to therapy experiencing anxiety. Hundreds of people, you can hear people in the grocery store talking about, I am anxious, but that person's anxiety is going to be very different than mine. So pulling in that great picture and providing treatment that's individualized is a big focus of the ASAM, which it always has been. And then creating that treatment plan with that client in mind with their specific issues, and then using the outcomes. Their payers, the ASAM is trying to push the same language. So we're all create from the patients to the providers to the payers using the same language. So we're all basing it on outcome driven objectives. And then, meeting that insurance requirement. All right, so some of the changes with the from ASAM 3 to ASAM 4 is we're integrating withdrawal management at all levels of care. So what that means is you could have an IOP, you could have a PHP where you're also providing the withdrawal management medications. You're watching. It can't be severe. It's the milder symptoms. It's the mild, those pause symptoms where you're still having that psychological withdrawal versus the physiological withdrawal you can manage at a lower level. And then biomedical services are on that continuum as well. So you can see it not only at ASIM level 4, but 3.7, 3.5, and even into our PHPs and IOPs. And then they've added that 0.1, and I'll show you in a pictorial in a slide before, but the whole point was to create that continuum of the patient's needs and go to various levels of care, because they do know continued supportive services our hallmark of keeping someone sober longer and in recovery longer. Readiness to change was actually removed. It's not a whole dimension by itself. It is incorporated in each dimension. So it's going to be crucial for us to bring that up in each level of care, because I might want to, I'm at dimension 3, I might be motivated, but physiologically, I'm just not ready. So that readiness to change can vary from each dimension. I just said that. All right, so removal of dimension 4, 5, and 6. Everybody kind of freaked out, like, what did they put in place? But I do like what they put in place. So that substance use related risk for dimension 4, dimension 5, and then adding that person-centered continuum. We no longer have 0.5s either anymore, and we're really focusing on that and that continuum of care, and focusing on both medical and psychological symptoms. Knowing I know that there has been a debate within the substance abuse world where it's either mental health or it's substance, and you've got some group of individuals who have always believed they're integrated and go hand in hand, and then you have the whole school of thought where substance abuse is not necessarily connected to the mental health. I do believe with these changes, the push is going into that direction to help focus that if you're lacking the coping skills, that may be where some of the substance use comes from. So how can we incorporate the two, whether you realize it or not? How do we get you there? So here's just a quick pictorial of the continuum of care, which the ASAM levels. New for us in the mental health and in the inpatient settings is PHP changed its name. And some people love it. I personally am just, why do we have to change PHP? Everybody knew it's now high intensity outpatient. They have a great reason as to why they've changed it. It just, some of us love it, some of us don't love it, but they've moved into that outpatient setting with a level of care, and then recovery residents, because some of us go into those sober livings, some of us go into those group homes where we have that continued support, but we're daily still exposed to a lot of our triggers, and we're out there still using our supportive services, but yet more independent. Here is a pictorial of the differences within from the 3rd to the 4th. It's just a pic. If you've seen the ASM website, you've seen this. It just makes it a little easier to see where they've kept some of dimension 5 and 6 and put them in there, what they've converted to, and how they're incorporated actually into the system. Okay, let's go to the goals of these updates. What fun, because everybody wanted to know, why did they change these? Really, it's just to get us all on the same page and using the same language, using same criteria. Not that we weren't before, but they're just trying to standardize it a bit more, but also reflect kind of the current zeitgeist of our mental health world. Substance abuse and substance treatment, I feel slowly that stigma is kind of tearing away like an onion, and people are starting to pay more attention to it, not in a We still have some negative areas yet, but we're still focusing. We're seeing how important it is. It's easier if you've thought about having to talk to families. Historically, people getting that collaborative information, you've seen parents say, well, no, they've never had a problem before. I feel like now we're seeing people be more open about it, especially in our individual or our family sessions, or when we're doing those individual sessions with our family, gathering collaborative information. They're more open. At least me and my practices, I've noticed just a more readiness to discuss it. Like, we're going to take some things off out of from under that rug and we're going to bring it up. So I think that the ASAM 4 is kind of incorporating that as well. Promoting that chronic care model continues. Person-centered, more holistic, integrated treatment. Great. I do love that fact, because many of us were already practicing that, and it's awesome because now we actually can bring that in. Now, it's not quantifiable in the sense of you're getting a score in this area, but you're able to use those interpretations you have, the insight, to help drive the scores. And I'll show you when we get to the scores. Here is a pictorial of the actual dimensions. These are what we're going to kind of focus on when we're moving forward, and then what we do. But when I say that not everything is scored, dimension 1, each, you've heard probably the language that they've used, drivers, dimensional drivers. All they're really, dimensional drivers are just criteria and subdimensions. So each dimension has their own subdimensions. These in the light blue, these are the ones you're actually scoring. So for dimension 2, we're bringing in sleep, which is very important, and I'll talk about that briefly as we go to that slide. But we're only scoring physical health concerns and pregnancy-related concerns. With dimension 3, lovely, we've got active psychiatric symptoms, persistent disability, and then what trauma. How do these things? You're not scoring cognitive functioning, trauma-related issues, or psychiatric and cognitive history, yet you're utilizing that to be supportive of what your score is going to be in that dimension. Substance use related risk, both of those subdimensions are rated. In our recovery environment, we only have the first 3, but we're bringing in cultural perspectives and substance use and the addiction. So that history and the environment you live in, it's going to have clout when you're supporting that score within dimension 5. And then dimension 6 isn't rated at all, but it becomes important. So I do like where we're going with this. We're moving into things that we were already bringing up and saying, but they need to stay in this level of care. Their home isn't good. They're still anxious. And it's keeping us there. Before, the client's preference didn't really matter. It mattered to us, but to the payers, they didn't. So this is going to give us some support in helping us keep someone a little bit longer if we feel like there are a few other things. Don't get me wrong, you're still going to have to support that with data. So we're going to have to figure out how to do that, but we will do that. All right, with dimension 1, intoxication and associated risk, we're just looking at their current level of intoxication. So when they're coming to you, what is their UDS? What is their breathalyzer score? When you do that first assessment, the CAL score, the CWA score, and what are their vital signs look like? You know as well as I do, vital signs mean a lot, because someone may not be forthcoming with their information and how they feel or what they're experiencing, but vital signs give us a lot of insight to anxiety, difficulty coping, other health risks. All right, withdrawal and associated risks. Here, we're trying to proactively identify the risk for withdrawal. Sometimes at that admission, no one is experiencing any withdrawal because they just had a drink or a shot or a hit of whatever it is they're using right before they walked in the door or while they were in the car. So we're able to identify and search for it. The nurses who are doing these initial nursing assessments can project and predict really closely, without a doubt, what this person's going to feel like in an hour or 2 hours or 3 hours. And with this associated risk, if you have someone that's experiencing absolutely no withdrawal symptoms, yet they have a history of severe withdrawals. You can bring that up. Oh, they have a history. Now, we've always brought that up in our nursing assessments, but I don't think it really showed where we would put that if we had history of seizures, history of blackouts. Those are important things, tremors, DTs. This is where you're going to put that information. And then the substance abuse withdrawal risks. What are those risks? Because we're incorporating what happened to us before and what could happen now. With co-occurring medical and psychiatric symptoms. I may be very motivated when I get there. I'm going to feel safe. I'm not stressed out, but I might be dealing with anxiety, depression, a bipolar disorder. Those symptoms may impede my ability to recover, especially if I'm also experiencing some mental health issues, some medical issues. My blood pressure's out of whack. My thyroid, the thyroid is a big deal. The thyroid being out of whack can completely negatively impact your ability to want to stay in recovery, because that system it's not homeostatic. It's not helpful. So bringing all these things in are very important. And then the addiction medications needs, that's always been a part of it, but now we're going to pinpoint it. All right, with dimension 2, we are looking at medication management. What are those acute health issues? Are we coordinating with providers outside, or are we going to have to start getting referrals ready to go forward? So they're wanting all this, and you've heard your if you are in a treatment center environment, I'm pretty sure you've heard your UR department say, what about discharge on the first day? Because we're starting to think about that. Your payers and your patient, they don't really want you to be there forever. When they first get there, they may think they do, but ultimately they don't. So what are we doing to help continue the support post-discharge? And some of those conversations start on day one. Well, they all start at day one. They should. Pregnancy related issues, depending on your treatment center or your personal perspective or your medical director's personal perspective, is going to support whether you're actually providing treatment to individuals who are pregnant. Now, there won't be any males, biological males pregnant, so that's a quick, easy no there. But with our females, we've got to get those testing done immediately, what complications, going over those risk factors, and then also what the patient's concerns are. Now, the subdimension sleep problems, exciting that they're bringing this in, because we do know if you're not sleeping right, you are not you're not going to be focused in group. Your motivation is going to be down. Your insight is just going to be very clouded. So when we're having sleep problems, we're looking at the causes, what variables influence that, and truly it could be you had no sleep problems before, but now that you are actually on the road to recovery and withdrawing or living without whatever substance you were using, you may suddenly have sleep problems. So that's a piece that we want to support in dimension 2. We don't rate it, but definitely bring that in. Using dreams, tossing and turning, nightmares, difficulty falling asleep, staying asleep. Those are all going to be things that we're going to want to figure out what the triggers are and mention them here. And sometimes our clients know, but then others, sometimes they don't. With dimension 3, we've got that psychological behavioral piece, and we want to make sure we're bringing them up. So again, you're only rating the first 3 subdimensions. The others are going to, I'm sorry, the first 2. The first 3 are going to support, the final 3 are going to support those first subdimensions, which will be very good. One important piece that ASAM is supporting is dimension 1 and 2. They're looking for medical provider, nursing providing input in dimension 1 and 2. They're not going to weigh heavily on a therapist or the clinical team's insight on dimension 1 and 2. They're going to take it. But if your physician is saying something different in dimension 1 and 2 than you are saying, they're going with that physician statement, because their license is, that's their scope of practice. Their license weighs heavier in those aspects. So just remember, when you are working with the ASAM dimensions, you do want to get provider input, especially for dimensions 1 and 2. And then you come in as a clinician at dimension 3, seeing how they all work together or not work together. So working seamlessly in with those three help us get to the next level of recovery. With that qualified provider being there now, dimension 3, what are they feeling? What are their actual symptoms? And a lot of people don't realize this active psychiatric symptoms, you can put some of your pause symptoms here, because most of our pause symptoms, when we talk about withdrawal, there's physiological withdrawal and psychological withdrawal, anxiety, fidgetiness, difficulty focusing, brain fog, depression, anxiety, guilt. All those things are going to go here in subdimension 1 because those are symptoms. And that's when you're asked, what are those pause symptoms? They're going to go here. And you do need to monitor those, because if we can't manage those here, it is a quick, fast, short road to relapse. We know that. With cognitive functioning, how engaged are we with our supports? Do they need supports? Do we have the cognitive impairment? So that brain fog, yes, if I have difficulty focusing, if I can't get out of bed, all those things are going to be supported here. And then the interventions, what are we given? And going back to what Rhonda was talking about with our interventions, you're going to actually bring those in here as well. Now, trauma, psychiatric needs, and persistent disability, they're not rated, but you want to gather as much information to put here. So exposure to abuse, history of abuse, how traumatizing are they? Was there no abuse, but yet they're traumatized from an accident, from a death, from wartime, or witnessing something very traumatic? And then what are our needs? How can we meet them at this point? And then what is our history of psychiatric needs? You know as well as I do, you get a patient who has passive suicidal ideation and everybody's like, they can go to outpatient. Yet, you know, given their history of a family member having committed suicide, or a history of severe depression in their family or within themselves, is a huge risk for actually increasing their relapse. So we want to bring all these things here and use them to support our level of care recommendation. And then that persistent disability, how worried are we here? That persistent disability is what we're talking about when Rhonda brought up somebody not wanting to get out of bed. Most of us don't want to wake up in the morning, but not getting out of bed and staying there and isolating is a big difference. If I am just dealing with that mild depression, so dysthymic disorder, I'm going to get up, I'm going to do things, I'm going to go to work, I'm going to cook for my kids, I'm going to engage, but I'm just going to feel detached from it. But when it is a high chronic level of disability, the problem is I don't want to get out of bed. I don't even know when the kids have eaten, and I might not care. I might not even remember my last meal. So how severe is that disability, and how much support do they need, and what interventions can we provide? I know when you talk to someone outside the mental health field and you say, oh, we had them sit on the edge of their bed, or we had them hold some ice, they think that we're weird. But we know that actually helps. So that if we can stimulate physiologically something in us and shift those neural pathways, moving up to the next level of engagement is much easier than just allowing us to sit there and stay in our bed. Because I would love to stay in bed all day, but sometimes we got to get ourselves up. And we all know, if we don't have mental health issues or haven't struggled recently or in the past, sometimes we don't get out of bed. But major depression, major disability isn't that I'd rather sleep for 10 more minutes or snooze for another hour. That there are big differences. All right, so ASAM 4, these substance use and related risks. What we're looking at is considering the likelihood that substance use and the level of harm that substance use is going to do to our life, but also the likelihood of the negative impact of our substance abuse related behaviors. So some of those behaviors are we determining the current risks and what's the negative impact? So that's why you're going to be asked in this area, is it negative? Is it destabilizing, or is it serious? Destabilizing could be me really just not wanting to engage. But serious could be me driving drunk, driving under the influence, or drinking and trying to go to PTO meeting. How serious that moves into the seriousness of life. When we are using this level of care, if we pivot into treatment planning, we want to use the full history when we're trying to figure out what challenges we're going to have with recovery and what strengths to focus on. Those service needs that we have while we're in treatment, and then as we continue, how do we provide coping skills and supportive services to support to actually reduce the harm of our interest or our thoughts in this engagement. Dimension 5, the subdimension ability to function effectively in our current environment is rated, and function and social ability skills. Very important here because we are looking at safety and we are looking at support. Where do we go? The only dimension that isn't rated is our cultural perspectives, because this is the cultural perspectives of our environment. Our family says they want us to be on the road to recovery and remain sober, yet they still have alcohol in the home. That's going to deter things. Are our social networks supportive of our engagement in recovery, or are they not? If all of our friends know you have a problem, but I don't, so I'll still drink, that creates an issue. And is that environment safe? Is your home safe? Free of abuse, free of trauma, free of someone basically negatively discussing your recovery? We want to see that support. The person-centered dimensions are going to be important because that's where we're looking at motivation, their interest in the level of care. What are their preferences when it comes to level of concern? What are their concerns? What supports do they think they need? And then how are we going to incorporate all of that information into our treatment plan and our aftercare plan? And sometimes our barriers to care or even discharge are gonna be those cravings, those constant obsessive thinking, and our mental health issues. Here is the rating scale. I just kind of chopped it up because if you've gone to the ASAM website, you've seen it's a very long sheet of paper, looks very confusing. However, I just chopped it up to just get the rating form with each one. Now, level 4 is always going to be that intensive med surge type environment. We've got IVs, we've got 24-hour medical and nursing care. The 3B 3.7, this is the 3.7 bio and the 3.7 non-bio are now your what you would have considered detox before, but it's in a residential setting. So you have high risks. We're monitoring you medically, but it's not as intensive of you needing IVs, needing to be constantly monitored with your vitals. And then let's see, it skips around. So I'm going to go to a 3.5. Where is it? I'm going to make it bigger. A 3.5 co-occurring. Any 3.5, that is our normal residential level of care inside of a residential setting. And then most of them are going to have the co-occurring with it. And then 2.7, 2.5, and 1.1 and 1.7. I want to, before I go into the example, because we have about 10 minutes, is determining the focus of ASAM and LOCUS. They have common features. ASAM didn't used to incorporate as much as our mental health, but LOCUS did. So it's looking at both of them. But their intention is the same, determining level of care, making those symptoms and level of care integrated into our treatment plan and individualized. They both use dimensional approaches. They're looking at the mind body perspective. So that tabula rasa is here. We know they're integrated and we're focusing on that biopsychosocial part of treatment. And then data collection. They both want to gather data to make it quantifiable to support, because we know, guess what, our payers really want to look at this. But guess what, so do your patients. They want to see that their depression is decreasing, their self-esteem is increasing, their locus of control itself is broadening to being more interior, and focusing on the risk and then using that common language. Callie, I'm not gonna let you say thank you yet. I'll come back to you. I'm gonna share my example. And if I don't get through it all, I will still share this with you guys, but I kind of expanded on Rhonda's guy that she had, Mike. And I won't read it to you, but when you first have an encounter, whether it's a phone call, whether you're inpatient or whether you're outpatient, you get a little snippet. And then when the person shows up to admission, whether it's outpatient or an inpatient setting, you get a little more information. And then once the nurse meets with them, if you're an inpatient or even a community-based program, you get more information. And so this is just an example of someone, that Mike guy, who's struggling with anxiety and depression. And it kind of shows how, as he's going through each level of integration, so the nursing, the medical piece, the psychiatric piece, the therapeutic piece, he's giving more information, and that helps give us that global perspective of someone. And so Mike centrally discloses he's not just a 43-year-old male struggling with anxiety and depression. Not what were those 4 overdoses? One of them was an intended suicide attempt. And how we're going to incorporate all of this information, because this is typically what you're gathering in your biopsychosocial, and gathering it from your collaborative pieces to get there, having the mental status, the biopsychosocial, the GAD-7 pieces. I will quickly, because we only have like 8 minutes left, I'm going to go into how I broke down the scoring for you. I should have probably focused on this one a little more, but with this guy, he has an ASAM rating of any for intoxication for subdimension 1 or 1, 2, and 3. Reason for that being, if we go back, when we gathered his use history, his last use was over 2 years ago. Please do not let that deter you from thinking that someone doesn't fit for inpatient or partial, because as we incorporate that psychological piece, you might find you're supporting residential versus partial, depending on the type of questions you're asking and how forthcoming they are being with you and how honest they're being with themselves. Because this man is suicidal. So he didn't mention that in his first phone call. He did not say, "Oh, I'm suicidal right now." He said, "I'd had one attempt in the past." But he brought in, "I haven't left the house in 3 weeks. I'm isolating myself. I'm sleeping during the day. And then I'm typically up all night thinking about drinking." So we've got those cravings. We've got those obsessive thoughts. And sorry to kind of go back and forth with you guys, but that's where we would support this here with any level of care. So he's not actively drinking. His BLS and UDS were negative. So we know he's not actively using at this point, but something's amiss because he has a history. So we're going to rate him at any level of care. Then with our withdrawal and associated risk, he didn't report any symptoms initially, and he didn't really discuss that except for his cravings and thoughts. So we're going to put him at any level of care. Subdimension 3, the addiction medication needs, is where we are. Is he actually being honest with us? He's having the cravings, he's having the using dreams. So we want to give him a further evaluation. So you want that psychiatric provider to come in and give you that evaluation to gather in hopes of gathering more information that may be supportive of your level of care decision. The biomedical with Mr. Mike, he had high blood pressure. He wasn't medication compliant, so this is an issue here. He's going to need support, so we're going to pick any. He's not pregnant. He's a man, biological male, admitted to it. He doesn't have any issues here. The sleep issues, the excessive sleeping, even though it's not rated, we want to put it in here to support our decision with, hey, we're still gathering information. We're not moving on to referring out, and we're not moving on to referring up. The emotional behavioral piece, that 3A is just the number. If you focus on the level of care, it'll simplify things in your brain. 3.5, residential, and here is why. He's depressed, he's anxious, he has suicidal ideation. We do have a trigger. You didn't get to see it because I went through it so fast. I apologize. But his trigger was he had been in treatment, met his wife in treatment. They both left treatment. We all advise not to do those things, but we know our patients do that. They got married, had a baby, but he does not talk to his family. He has no contact with them. His father was abusive. They're still using and drinking, so he separated that. But what did happen was he heard from an aunt that his father was diagnosed with cancer. He doesn't have the coping skills to deal with that, and that was the trigger for his suicidal ideation and those cravings and wanting to go back to drinking. He knows he can't do that because that's a pact he made with his wife. We're not going to drink. We're going to stay sober. We have a child now, and he's on the edge. He hasn't used yet, but it's on his thoughts. It's in his forefront. He's isolating himself. He's not getting out of bed. Oh, and one little caveat, he lost his job. So everything is kind of somewhat falling apart for him. So there's the kick in for the SI. And that's where we're going to put in here that we want that 3.5. It could be any level of disability because we don't have the option for the 3.5 here in this rating. But he's not motivated to get up. He's scared. Cognitive functioning, not rated. Trauma, not rated. But look, we've got the history of abuse. We've got any related needs. I didn't bring up the issue with his father, but we want to put that there. The cognitive and psychiatric history, we've got substance abuse, a history of ODing, and the treatment. Here, we've got that substance use related risk. We're at E minimal because right now, not getting out of bed, not being motivated, the constant cravings, that is negatively impacting him because he's not engaging. We didn't even touch on what are his parenting responsibilities. Is he able to engage in those? And then, so he's not using, but those behaviors are negatively impacting his road to recovery or maintaining recovery. And then I use the same thing for likelihood to engage. And I'm going to speed up. I apologize. Recovery environment. His wife is supportive. She wants him to be sober, yet he's not utilizing his skills or his coping skills right now to maintain. He is struggling. He is one more stressor away from using. His safest home. I mean, his safe is home. His home is safe. So we don't have any needs there. His wife is supportive of sobriety and recovery, so we don't have any needs there. Cultural perspectives for use. There isn't a stigma because his wife is also in recovery and she's supportive, so she's there. Those person-centered considerations, that barrier for him for treatment or even a positive outcome right now is his SI, his isolation, his cravings, his dreams, his coping skills. He does prefer inpatient. He wants to be in RTC and he's motivated. So therefore, when we get to the bottom of our rating, we're using 3.5 co-occurring. So we're actually recommending residential care, and it is the 3A. But with that, I could spend 2 hours probably rating and going through the ratings of the ASAM. And I apologize for getting kind of rushed at the end, but I do think it's an area that we're all really focused on right now because we're all trying to transition from therapists to medical providers to the UR teams to the payers. The payers are still struggling with it as well. So just know we're all on the same page. We're confused, but we're trying. Thank
Yes,
you.
and I just want to add one quick thing, Audrey, before we wrap up. I know
Yes,
we're at
ma'am.
time. I think something that's really important is all the specifics that you just touched on, Audrey, as we go down like the specifics of the dimension or the locus. That
Mhm.
is specifically what you want to target in the treatment plan. So we don't want therapists just kind of sitting thinking of what am I going to do or being generalized. Be extremely specific to all of those areas and use that as those that's your treatment considerations for your goals, your objectives, and your interventions. So just a wealth of information today, and we just have to get them to understand how to incorporate it. So thank you all.
Thank you all, most definitely. Thank you.
And just a quick reminder, we will be back next month, September 26th, with Lauren Bentley. So if you are on our email list already and you've received this email, you'll see another one next week with the follow-up. Again, a reminder that the slides recording resources will be available next week, and I'll send out the registration for September again in that email. Thank you both so much today. This was really beneficial. Great
Thank you.
questions. All of the above. We appreciate your time. Have a great rest of your weekend, everybody.
Thank you, everybody. Enjoy. Bye.
Thank you, everybody. Most of the questions I got to in the chat.
Oh,
If
thank you.
not, reach out to us. Okay, everybody, have a
Yeah,
wonderful
you can
weekend.
email
Thank
us
you.
in pbhu@promises.com if you have any questions that didn't get answered. Okay,
See
Thank
you
you,
thank you.
all.
everyone.
Bye
Bye.
bye.